Our next presenter is Intuitive Medical Health. Ravi Hariprasad is the presenter, and he's a Cornell-engineer turned Harvard-trained psychiatrist and public health specialist. Man, this guy can cover everything. IMH is poised to redefine mental health care, and his unique journey spans from being first clinical hire at Ginger, and which is now called Headspace, playing a significant role in its transformation into a leading telemental health company. 2, pioneering a large-scale mental health primary care integration utilizing similar care model at Kaiser, benefiting 200 PCPs and 5,000 members. So we do share that ex-Kaiser label, but obviously Ravi is much more accomplished. So Ravi, the stage is yours.
Thank you. Let me get these slides up. So good evening, everyone. Thanks for taking the time, and I'm happy to have the opportunity to share with you guys a little bit about my latest project, which is Intuitive Mental Health. We are a mental health startup, but with a very different focus and twist than what you may have seen out there in the past. Let me start by framing the problem. There is an epic crisis in mental health access, and it's been brewing for decades. Too many patients, not enough psychiatrists and therapists. And then post-COVID, the amount of demand for mental health services skyrocketed, and it's not letting up anytime soon. And part of it, too, is the destigmatization of mental health. Like, it's no longer carrying the stigma that it once used to. And when I look at this problem and think about how to tackle it, I keep coming back to the simple fact: 80% of all antidepressants and psychotropic medication is prescribed in primary care by primary care physicians. It's staggering, right? Only 20% are dealt with in specialty mental health services. And a majority of these patients in primary care never receive any additional mental health support of any kind. They often just receive a prescription. And the PCPs are not equipped, designed, or even wanting to deal with delivering mental health, but they have to do it. Where else are they going to do it? It's kind of like the metaphor, since we're on the topic of diabetes, if every diabetic thought that they needed to see an endocrinologist to get insulin, there would be a lot of dead diabetics in the country. And mental health services are inevitably going that way, that there is mental health needs to be a primary care function, and the support is not there yet for the PCPs. And so that's the problem that we want to intervene on. How do we deliver high quality mental health services in primary care to move the needle on the mental health access problem? So this company is as much a mission for me as it is a service delivery company. And you know, I want you guys to kind of imagine with me for a second, you know, a world where anyone can have immediate access to mental health services right from the PCP that they trust and know. And it's seamless, comprehensive, and it encompasses more than just medication. It's an approach to their well-being. And on the other hand, think of yourself as a physician. And I know there's lots of physicians in this audience, a world where a PCP can have on-demand psychiatric consults and have an unprecedented level of support from a team that supports their patients. It once seemed lofty, and I've probably spent a good portion of my life trying to crack this nut and figuring out how to do this. But I think I see the way forward, and I see a path to getting us there. And I want to walk you guys through that journey and get your feedback and see what you think. Let's start with the basics. Collaborative care. So in typical primary care, you just have the patient and the PCP. But in a model of care known as the collaborative care model, they call it COCM, you're adding to that a mid-level psychotherapist, like a social worker, and a psychiatrist as a consultant, and a registry collecting data on patient outcomes so that they can be followed longitudinally. These components, when added to a primary care mental health model, tremendously level up the caliber of care that you see. It's been replicated that the collaborative care model can lift outcomes by 50% or greater over and over. So there's no mystery to this. And it happens because it's a patient-centric model. We're looking at this at a population level. We're measuring outcomes on a routine, regular basis, and we're treating these patients to target. And we're using evidence-based care, and people are accountable. There's nothing new about collaborative care. It's a 30-year-old model, and there's probably 90 RCTs for the National Institute of Mental Health. It's one of their 4 aims is increasing service delivery, and collaborative care is the principal approach to it. But where I see the opportunity for innovation is in tech leveraging this to actually add robust workflow management, artificial intelligence, and all of the innovation that we've seen blossoming in mental health since my early days at Ginger, to the robust ecosystem of point solutions that we have in the market today, and bringing them to bear at the right time in the right place to the right patient. That makes a difference. And then there's the other arm of my vision, which is that it's not enough to just give people drugs, medications, and send them on their way. And I'm not sure at this point in my career that talking about it ad nauseum is actually going to solve that either. What we need is for people to start sleeping, to exercise, to eat properly, to meditate a little bit, and to have community and connection. And so this actually turns out to be something that's actually fairly affordable to deliver. And so the component of IMH that really inspires me as a healer is not only adding these tech leverages and efficiencies. My first degree was in operations research engineering at Cornell, so that naturally is something I gravitate to, but also in a vision for rebooting these people's lives and showing them how to thrive instead of just getting on. And the combination of psychopharmacology along with lifestyle medicine is incredibly powerful. And I intend to bring that to mainstream and show people how it's done. Just a little taste of the kind of innovation that I'm talking about that should resonate with every physician in the audience. Yeah, one of my teammates thought that it would be good to discuss this a little bit when I was all excited talking about how I was seeing patients this week. Typically we're all running behind on our schedule. We're like tightly packed. PCPs sometimes only have 6-minute appointments, and it's hard to like stay on schedule and do what we need to do with our patients. Often we're running into the room, we haven't even reviewed the chart, and we're looking at the chart. Some 40% of a physician's time is spent in front of an EMR, and we're not connecting with the patient. And then we have to write a prescription, and then we have to run off to the next session. And it's no wonder that PCPs are burning out at alarming rate. All of us are, actually. It's a hard thing being a doctor in this environment. The IMH way? In advance of our appointment, the AI reviews the medical record, the pre-visit forms that the patient filled out, and their outcomes measures. And it creates a summary for the physician, checklist of critical points that must be discussed during this appointment. You might get an alert that this woman just delivered a baby. Make sure you're screening for postpartum. This woman is on a medication that's unsafe for lactation. You should check in on that. She's reporting side effect of insomnia that has been persistent for the last 3 appointments. Check in on it. And then you talk to the patient. Engage with them. Don't worry about taking notes. We got your back. Just pay attention and do your job and connect with the patient. Explain your treatment plan and approach. Afterwards, the AI processes a transcript of that interaction and delivers to the physician a very nice, readable, usable, actionable progress note, along with tips and insights for the clinician, showing them what they could have done better, the things that they did do better well, and giving them some level of feedback to ever level up their quality of care. And then it generates a post-visit text message that you can send to your patient that engages them and summarizes the treatment. This particular case is a patient that I saw this Monday. We'll call her Jane, who just had a baby, and it was really tough because her mom is wanting to move in with them, and she has a bad relationship with her mom, and not knowing how to say no. And the session was focused on how to set boundaries and how to hold them, and how to negotiate those things. And this was able to recap the session, use emojis, motivate the patient, explain, reiterate the fact that it's completely normal to have mixed feelings about your mom's visit, prioritize your well-being, and set clear boundaries. It's okay to say no if it's best for you and Casey. Casey's the name of the baby. And so this is something that we wouldn't have time to do in our rapid fire meetings. And after I was done with this patient, I went on to the next one, comfortable and relaxed, and continued with my work. This kind of clinical power is available right now. And when I was talking of it a year ago, it sounded a little futuristic. And now people are starting to understand that this is happening. And in 6 months, it's going to be mainstreaming. So I see a revolution in the kind of care we can deliver, and the quality and the improvement in our lifestyles. And there's not one aspect of care, including its scale, that's not going to be impacted by the revolution coming up. So just to recap, the idea is that IMH's service is a collaborative care model that's turnkey to PCPs, minimum friction. We show up and we bring our own care managers and psychiatric consultants, and we use our tech platform to manage all the balls. We partner with the PCP, we assess and continue to follow these patients, and we create new revenue for the PCPs. And these fees are reimbursed by all insurance companies at this point. So that segues into the business model, which I think is actually the strength, a very powerful strength of this company. And, it's not so much that I want, this company is a mission, but every mission has to have a sustainable business model behind it for it to sustain and grow and to develop and create the resources it needs to do what it needs to do. There are 2 CPT codes that came out in 2017, and they were spottily covered. And in 2022, Biden decided that collaborative care was going to be one of his 5 signature initiatives for beating the mental health crisis. And he got all the payers in the country to pay for it. There's 37 out of 50 states where Medicaid is paying for it, and the rest of the states are likely to come online over the next 6 months. But Medicare, all commercial insurers are paying for it, and it pays well, on average of $175 per patient per month, anytime a PCP is engaged in collaboration with a psychiatrist, a therapist, and using a registry. The rest is capitated. How we deliver the care is up to us, which creates this ultimate vector for innovation and breaking out of the traditional doctor office visit model. And the other advantage is it's a PCP code. So the PCPs are able to deal with the revenue cycle for us using their standard billing practice. They just send another claim out, and we do a revenue share with them. If you look at the math, a typical PCP might have a panel of 2,000 patients. Conservative estimate is 20%, or about 400 of those patients will have some level of mental health burden. And if we capture just 40% of that possibility with a PCP, it's 160 patients. And that actually yields 28,000 in new revenue to the table every month. The PCPs are able to keep 6,000 of that revenue, which is about 70,000, which is actually a reasonably important lift to their paycheck and to their salary for engaging in this collaborative care model that takes this burden off their shoulders. There's actually a study that was done that shows that physician PCP burnout goes down 50% when they are involved in collaborative care models. So I think the uptake is going to be quite exciting. And meanwhile, that leaves a robust amount of money for us to deliver the kind of care that we want. In fact, when I was picking the URL for this company, I got imh.care, because our focus is actually moving from telehealth to care, where we hold on to the cases and track these people to completion. The mechanics, each PCP with these kind of conservative numbers is about 250,000 in annual recurring revenue. 20 PCPs on our platform gives us a 5 million run rate. I think that's quite compelling. Market, I think, is pretty obvious. It's massive. If you just do a bottoms-up calculation on the number of family medicine and internists that are doing PCP work times the numbers that I showed, you're looking at 15 billion in this country. And that's leaving off the table the possibility of doing this in OBGYN, oncology, pediatrics, massive markets. How many kids are getting psychostimulants with absolutely no monitoring from their pediatricians? It's scary, actually. But what are you going to do? You're the pediatrician. There's no child psychiatrist around. And globally, the market for mental health services is $250 million. So it's a huge market. It's growing. And even conservatively, it's powerful. And the dynamics are, we're at a flashpoint, right? Just last month, Kaiser got fined $200 million from the Department of Managed Healthcare for having access issues. And that's in a state-of-the-art healthcare system that does its best to manage access. I think that outside of Kaiser, the problem is vastly worse. It's just that Kaiser is regulated, being an HMO, but 200 million, and they have to spend 150 million of that to increase access over the next 5 years. And meanwhile, the Senate is creating a caucus and a committee to try to tackle this. It just keeps going. It's a big problem. And this may be the perfect time for a business. A wise mentor of mine once pointed out that timing is everything in these businesses. And I think that's true. You know, you've got support politically all the way up to Biden on this issue. You've got a Medicare pushing through, CMS is getting legislation through Congress now to increase payout on these CPT codes to 175% of the fee schedule in year 1, 150% in year 2, and 125% in year 3 to get PCPs to move on this. And the demand is just explosive. And all the payers are paying now and paying well. And meanwhile, this allows for a level of scale that we just don't understand yet. And the actual model of care, of how we move people through the system and how we track cases, lends itself to brilliant tech leverages. The tools are there. It's time to put them to use to heal these people. I'm blessed. My team is coalescing brilliantly, and I'm really excited to share a little bit about them. First, a little bit about my background. As Uli pointed out, I've spent my lifetime preparing for this company and putting myself in all the right situations to gain all the skills with my bare hands to know how to do this and how to navigate it. I have a dual engineering background in computer engineering and operations research from Cornell. I did my medical training at University of Pennsylvania. I picked up a public health degree at Harvard, and then I did my psychiatry training at Mass General. And then, you know, relevant to this, I was working at Kaiser, and I think I overlapped with Uli a little bit there. And I actually built a collaborative care model there, backing up 200 PCPs over a 500,000 patient population in the East Bay. And it was exhilarating, right? Like figuring out how to keep all the balls running and how to deal with the demand and to support these PCPs in a way that, well, I'd always pick up the phone and say, "How can I serve you?" And I would do that over and over and over, and learn what our heroes needed, and figure out how to teach them how to do this, how to care for these people. And then I left Kaiser and I went to Ginger, which is now Headspace, and I was the first clinical hire, and helped pivot that company from the data science company that it was to the mental health juggernaut that it is, using integrative care protocols and mindfulness. And I've been practicing mastering the art form of what actually to do for these people on a holistic level for the last 6, 7 years, and have treatment protocols and approaches that are both data-driven, algorithmic, and holistic. People always thought you could only pick 2 of the 3, but I got all 3 now. And joining me is our clinical ops lead, Coleman, who recently left Heal Communities, which was acquired, and they delivered lifestyle medicine as an overlay on primary care with a very novel model. Curiously, this guy actually launched that product at my first customer's site. So it totally de-risks this launch having him on board. And Ryan Cochran is a serial entrepreneur. He's had 3 unicorn exits. Um, he was one of the first hires at Clover Health, which exited at $6 billion IPO. Bright Health, which was a $1 billion exit it was a payer in the value-based care market. He recently sold One Home to Humana. And he's been very involved in helping me guide the vision of this company so it hits its target. And then we got Sri Muthu, who is an amazing guy who's helping as the interim CTO of this company. He is the founder of Zell. He was at Wells Fargo and running their innovation lab, and Zell was his baby, and he took that to the finish line, and then started Health Venture, which was an accelerator for digital health and tech-levered services company, where 3 or 4 other companies got launched. He's a man of tremendous skill and vision. And Jonathan Wan is a product and project manager extraordinaire who joined our team this week to keep track of all the balls and make sure that our launch goes without a hitch. And that brings us to our progress. We signed our first customer, contract signed, sealed, done this November, a couple of weeks ago, and we're in the middle of getting ready to. No, we're launching now, and we're in the process of it. I'm so used to saying we're going to launch, but it's happening now. And our customer is iconic. It's ideal. This is a customer that is one of the banner institutions of the American College of Lifestyle Medicine movement that anchors lifestyle medicine in their practice. So the combination of IMH with that practice will be a ton of learning on how to integrate these holistic interventions into a high-speed primary care insurance-based model. We're looking at getting to that ever critical 1 million run rate sometime mid next year. It's only going to take 700 patients. We have a total of 3,000 likely patients in that practice we can get at, which will give us a 4 million run rate. And it's a direct commercial client contract. There's no pilot here. And it's the perfect mix of government and value-based and private payer payers. So we're going to be able to play in all of those spaces. So really excited. This first client takes us way ahead into our 2024 projections for sales. And we have a pipeline that's quite building up with other prospects after we get catch our breath. And so I've been self-funding this company to this point, and I feel like I could use a little bit of angel money if anyone wants to join me on this vision and give me a hand. We're trying to raise a 300K angel round sometime to close this January, December, sometime soon. And that'll give us the funds that we need to serve this first customer well. And at some point on this journey, over the next couple of months, we're looking to raise a full 3.5 million seed round, which will really allow us to kick our development and our infrastructure for the company into high gear. So that's IMH in a nutshell. Happy to take any questions.
Thank you very much, Ravi. Yeah, that was a great presentation. I'm sure our audience have tons of questions on how you're able to do this, and congratulations on your first customer.
Thank you.
All right, questions from the audience. While they're thinking, so in a way, it is more of a services company, right? It's more services, tech-enabled services. Does that kind of fit the description of what you're trying to do?
Yes.
Okay.
Tech-levered services.
Yeah. Now, why do you think that the traditional players are not doing this? Why are they not doing it? When it sounds like it's a doable thing. Is that because they're not innovative enough, or what's the hurdle there?
Well, so it's first of all, it's a primary care function. So these codes are in the primary care taxonomy. So then there's a huge inherent dilemma, because we're asking a PCP to figure out how to hire therapists and case managers and psychiatrists and figure out all the algorithms and whatnot. Like, how is that going to happen? So that's one huge barrier. And second thing is, for other startups and people who have been trying to do this, it's formidable, the logistical challenges of how to interdigitate with PCPs, how to take care of people in this model. It's not something for the faint of heart. I don't know that I would have the courage to be so ambitious with this if I hadn't already run a large one at scale and figured it out. So it's not something that, your average telehealth startup is just going to jump in and say, oh, bring every case in primary care to us and we're going to take care of it. So I think it's partially the skill of how to execute it. And then lastly, I think the lack of technology, like the existing collaborative care models that we've seen, don't use a whole lot of technology. They just throw care managers in there with an Excel spreadsheet, and there's a psychiatrist with a cell phone. That usually leads to burnout for the clinicians in the system, and it doesn't work too well. So at least it doesn't scale too well, is what I should say. I think the combination of using technology, of having robust operations, operational excellence is going to be the heart of this company. And then scaling these clinicians. It's already a highly leveraged model, right? Psychiatrist goes from 500 patients to possibly 10,000 or more all of a sudden. Yeah. That's how it works. The PCPs are actually acting as trainees, if you think about how this model works. And so that scale, along with AI, I think is going to be hugely powerful.
Okay. So yeah, agreed. So I see that definitely the quality of care, the patient will definitely benefit from this model. And I see that, primary care doctors will also benefit, because obviously their workload goes down, and, you got the two of the three key factors for for physicians is decrease workload and increase income.
And don't make them do anything differently.
Yeah, exactly.
You need that one.
Now, what is in it for the insurance companies?
So there's been a lot of data out there that's published in peer-reviewed journals on the economics of collaborative care. It's well established. $1 spent in collaborative care leads to $6.50 of downstream savings in terms of its ROI to a payer. So that's established.
Okay. So I guess in a way, you're going to enter the
They're
market.
incentivizing and encouraging it, the payer attitude towards this. And then if you
Yeah.
go look at a value-based care environment, we
Yeah.
know that the heart of value-based care is treating the mental health burden in the population. Think diabetic who wakes up in the morning depressed and pops open ice cream and shows up with DKA in the emergency room later on in the day, right?
Yeah.
So, but no one's able to actually do that. How do you actually treat the mental health in a population? And collaborative care provides the vehicle for doing that. And so if you're at risk for the dollars and you can drive down the mental health burden, it's pure profit to the system.
Yeah. So I see those two, approaches to the market. One is, where you're going into fee for service and increasing, physicians' income and decreasing their workload. On the other side, I see that in the value-based care market, you could potentially decrease the total cost of care and provide excellent service and prevent, further deterioration of the condition. Why did you pick one over the other? Why did you pick the fee-for-service market versus going straight to value-based care?
So when I look at other people who have played this game before, I think the mistake they've made is gone too big too fast. And
Mm,
I am patient. I know that the demand is infinite in front of me. And I know that the payment for such infinite demand is going to be there. And so it's a real question of getting that Apple-like experience to all stakeholders, right? I want patients' hearts to like melt when they feel the care that we're affording them and the fact that someone's watching over them. I want PCPs to feel like someone finally has their back. And it's as simple as just asking, and they can get what they need instantly. And so I don't want too much scale too fast. I want enough patients that I can build this correctly, test it, and get all the workflows optimized and the technology right. And then just like and
I see.
so, fee for service, I don't need a contract from anyone. I don't need to negotiate anything. You just bill 99492 and go. And I
Yeah.
waited. I had a lot of choices on the first customer, and I waited for this particular customer that was just right. Both values,
Yeah.
vision, and type of practice. So I think it's very clear that we can scale into any of these environments after we get the formula right.
So then, uh, is it also possible that the sales cycle will be shorter with a fee for service provider versus a value-based care healthcare
Oh,
company,
totally.
right?
Totally. We have a pipeline of people who are ready to sign up right now. You mean we get extra income? You take care of our mental health problems? Like,
That's a win-win-win situation.
yeah, everyone wins. It's like a very
Huh?
carefully thought out business that, like, um, mm, uh, yeah, it's the idea.
Right, great, great. Um, is there any plan for the customers to pay? Is some premium or some kind of service, or it's all totally insurance and provided?
100% insurance is the plan.
Okay.
The financial modeling of the company is based just on those two collaborative care codes that make a very exciting and robust business case. But it leaves on the table the opportunity to tap into remote therapeutic monitoring, remote patient monitoring, and we have our method for getting insurance reimbursement on coaching services. So there's a ton more revenue on the table if we want to tap into it. But for now, it's simple off that, and the patients just. And by the way, these collaborative care codes, not only are they paid universally, they have the coverage policy of an office visit. So it's easy. You just pay an office visit copay, and they're good for a month.
Yeah, yeah. I see Mark Weston has a comment, but he can give you a whole lecture about this. Let's get Mark on the camera here. Mark, are you there? He says about 5 various paradigms here, including medical home. All right. Hema asks, is mental health a bigger problem in the younger demographics? And is it bigger in adults? I mean, as a percentage wise, or
I'm not sure on the exact breakdown there. I think it's ubiquitous to humanity, right?
okay.
Like ever since the first baby crawled out and realized that it didn't have milk, the thing started. And for eons, everyone's been trying to solve it. And so I think the children have problems, the young adults have problems, the mid-aged adults have problems, the seniors
Yeah,
have problems. It's ubiquitous.
it's a universal issue.
Yeah.
Sharon asks, is this service embedded into EMRs or patient portals?
So we like to stay EMR agnostic. So the idea is to actually bolt on to we're going to have a parallel portal that allows the PCP to have a dashboard, right? And see their patients. Green light means everyone's good to go. Yellow, check in with us. Red means we're in the middle of hospitalizing the person. As simple as that. And our care managers will be documenting in the PCP's EMR so that they can submit claims on it. Beyond that, we're trying to stay out of the PCP's workflows so that we don't have to create friction in their system. As a scale version for CareOS, our bigger platform, after we get out of our MVP, we'll probably have EMR integrations, which will allow for some more intriguing population health functions.
So you're expecting it totally run outside of the PCP environment, and then you're running a parallel system, and at some point it'll connect for billing.
Yes. Yes.
Okay.
And because with physical health versus mental health, it's not hard to do that.
Okay. So you're going to track these patients in your own system, the progress.
Correct. Yes.
Correct?
We'll have our own registry.
And you'll be giving PCP updates if they want to.
Yep.
So the other question she asks is, do you have any alerts to the PCP for high-risk mental health patients? Do they get alerted, or do you handle it by yourself?
When they're high risk, we handle it.
Okay.
And we make sure that person gets to the right place. And the PCP, their alert would be more of notifying them about the
Just
interventions we're
FYI.
doing and status updates and kind of like tracking so that they know, and entries into their chart. But that's the point, is we take over.
Okay. My question is, has this model worked previously better in other specialties? Now right now you're talking about mental health.
Yeah.
What about other specialties? Have you seen this model work?
So the notion of collaborative care with a PCP, yeah, like it would work great. Like imagine if you had an endocrinologist who followed with a PCP and they had care managers in the middle, and they automatically grab the cases. Is that what you're talking about? Or are you talking about?
Yeah, something like that.
Yes, there's
So it would
some
work.
evidence that people have tried these models, particularly in integrated delivery systems, where they're held to quality metrics. But yes, in terms of these codes, they only pay for mental health, and I'm not aware of other professions that have this kind of infrastructure to get paid for doing this. But theoretically, it's a brilliant strategy for any specialty care.
Yeah. I think that codes and the timing is what you were emphasizing, that this is now is the time that where this can click and,
Well,
and expand.
when these codes came out in 2017, they were paying out very spotty and inconsistent. So how can anyone do business in that environment? A PCP can't guess which patient to refer or not. And so now it's green space, and I believe that we're going to see over the next coming years multiple people entering this space. And Godspeed, I hope everyone's successful. We need as much help as we can. It's an infinite market. But I see a really brilliant vision for how to execute on it.
Yeah,
Let's see
yeah,
how it comes up.
that's great. Patricia asks, are you going to use AI on your side of the equation, or is it just one-on-one, person-to-person type of care?
So I'm not sure what is
So,
what she.
so what part of the care delivery is AI based, or is it? Yeah.
Got it. So initially, we're going to take the most repetitive and painful tasks and automate them with AI. It's going to be a tool that the clinicians keep as their superpower. And then we're also going to do things to level up care. So I gave the example of how we see patients using AI and how that augments the whole situation. But it's still the doctor delivering the visit and connecting with the patient. And as we go deeper stack, probably sometime next year, we'll have AI coaches that are taking the targets. Like, so this mother who's having problem setting boundaries with her mother will have a limited scoped AI model that will interact with her and trained on our protocols for setting boundaries in relationships. And that AI will report back to our care managers on their level of mastery and help them get whatever resources they need. So the key is to scope the task of the AI agents when you use them very narrowly and train them on exactly the task to be done. I've been doing this for about a year now in my own practice and watching its success. It's brilliant. And so, and then over time, as this company continues to scale, we can let our imagination run wild on what's going to happen. But for now,
Sure.
the AI helps the clinicians.
Great. So, but the majority of care is delivered by the physicians. Okay.
Yeah.
Great. Let's see. Any other questions? I know Patricia has a ton, but we don't. Let's go to other people. Anybody else? Let's see. I don't see any raised hands or anything else. So yeah, thank you very much. So I think that's it for today. And you know, this sounds very exciting. You know, I will definitely share this with Patricia has her hand raised. Patricia, go ahead.
Yeah, sorry, Uge. I think it will be very beneficial for everyone to know if those tests that you have done with AI were based on a constitutional AI.
No. And they were done with a large language model that I host myself.
But generative AI.
Generative AI, yeah.
Okay. And
so the trick is, Patricia, the trick is not to use the AIs to do the clinical work. That's not the point. The point is, yeah, right. So then when you have clinician oversight and it's automating tasks for you, it's very I don't know. I don't feel as threatened by the downsides of AI doctor.
Yeah, but I understand because a year ago we didn't have constitutional AI, but now that we have it, I mean, for me it's like I mean, I thought that it doesn't make any sense to not work with constitutional AI in healthcare.
Yeah, there's going to be
the newest technologies, and we know that, you know, it's going to scale also.
Well,
better, right?
We have to see. We have to see the examples and see how it goes, because a lot of people are testing different models, different things, and different types of AI.
Task, right? I'm hoping this company is going to provide leadership on how to do this ethically, responsibly, and safely. And it's going to be a wild west out there. And so a lot of work is going to have to be done on safety and on efficacy and suitability before these things
Exactly.
go
And
mainstream.
that's where I wanted to go, because if you already start working with a constitutional AI, you have most of the work already done.
Well,
You
you'll
don't
be
need
the
to
you'll be the
do.
test case, and you'll publish that, Patricia.
Yeah. No, I would love to talk to you. I have connect with you on LinkedIn, because I
Yeah.
think, I know a couple of companies here in Miami that I think that I would love to make the connection. I
Sure.
think
Yeah,
it makes a
fantastic.
lot of
Reach out to me.
sense.
Give me an email, give me a LinkedIn, and let's talk. Would love it.
Yeah.
Great. With that, on that note, we can, I guess, close this
And
program. Is there
yeah,
any
we
way?
will connect. I will ask you the questions.
Sure.
Fantastic.
I'm sure she'll have a ton of questions. She's one of our candidates in our accelerator.
Yeah, and we have overlapping. So
Yeah.
Awesome.
All right. I don't see any other hands raised. I don't see any other questions. So thank you very much, Ravi. And also thank you very much, Hema, for presenting. Lavinia says, great presentation. Thank you. And are you enrolling beta testers?
Who have a beta customer?
Exactly. Well, yeah, exactly. So yeah, the whole customer segment is open now.
I think we just
So
have
that's
to
great.
do it. All right, guys. Be
All
well.
right. Good
Thank
luck.
you for taking the time. And
Good
I
luck.
look forward to connecting with anyone who's interested. Take care.
Thank you.